Thank you, Dr. Fawaz. Thanks for the organizing committee. We know that TAVI is here to stay, and recently TAVI has moved as class 1 in the guidelines for patients more than 65 years. And the decision is based on the patient age, life expectancy, and patient preference. And this evidence comes from the overwhelming evidence from studies that TAVI is superior to surgery in patients with low-risk score. And it came from 3 randomized trials and 3 non-randomized trials. In these trials, patients' age was between 68 and 79, and score was between less than 4, and there was low risk of comorbidities. And meta-analysis of these 3 trials plus the low-risk TAVI patients showed that with TAVI, there is 39 relative risk reduction in all-cause mortality at 1 year and 45% reduction in cardiovascular death compared to surgery, along with lower risk of stroke, MI, heart failure, hospitalization, and very significant reduction in AF, acute kidney injury, and major bleeding. And there was no difference in major vascular complication, endocarditis, or valve intervention. However, permanent pacemaker and paravalvular leak was higher with TAVI. So the conclusion is that TAVI is a preferred option in patients who are low risk and more than 65 years. However, eventually TAVI will move to young, and in moving to young, what do we need to consider? Since many patients who are young, they prefer to avoid surgery, splitting their chest, and they are leading active lifestyle. So what are the concerns of TAVI if we move to young? First, what's the TAVI outcome in these patients? Very little, less than 10% of patients were less than 65 years in the trials and registries, and they were either intermediate or high-risk patients. So again, what's TAVI, the safety of TAVI in these patients? What about bicuspid aortic valve, which will be encountered more when we move to young patients? And again, the issue of durability and the issue of TAVI and the risk of surgical explantation. So what's the current evidence of these patients? If we consider outcome, we know that TAVI is superior in terms of all-cause mortality, cardiovascular death, better hemodynamic, lower AF, acute kidney injury, and other complication. And surgery may be superior in terms of permanent pacemaker implantation and paravalvular leak, with no difference in other major comorbidities. In terms of paravalvular leak, we moved ahead, and with the new valve designs, more than moderate paravalvular leak is not an issue. With Ultra, it's almost 0 to 0.1%, which is much lower than surgery. And with Evolute Pro Plus optimization technique, it's between 0 and 1.6%. So it is lower or equivalent to surgery, and we achieved good results with the new designs and new implantation technique. However, mild is still an issue, but there's controversy about the effect of mild on outcome in these patients. Permanent pacemaker, we are down to single digit now, and with improvement in the technique and the cusp overlap technique, the risk is equivalent or again lower than surgery. And we have to know that from the current evidence, pacemaker has no effect in outcome in these patients, as shown in 2 recent studies published in 2020, and also from the Swedish Heart Registry, where patients were followed up to 10 years, and there was no difference in all-cause mortality, heart failure, hospitalization, or cardiovascular death, whether the patient had or did not have a pacemaker. And in meta-analysis of 21 randomized trials, patients' dependency on pacemaker was less than 50% at 1 year. So most of these patients, they recover. Again, coronary obstruction is extremely rare with TAVR, and even rare with the valve-in-valve, whether surgical or non-surgical. Coronary access in young patients is always an issue, since they may develop coronary disease or acute coronary syndrome. With balloon expandable valve, probably it's not an issue, because less than 9% will have difficulty in coronary access, but this is more of concern when you choose a self-expandable valve in younger patient. Again, another issue in young patients is bicuspid aortic valve, since it was excluded from most randomized trials. However, in the bicuspid low-risk TAVR trial, 30 days mortality was 0, in these patients and stroke, and more than mild paravalvular leak was very rare. And again, in the evaluate low risk trial, the 30 days mortality and stroke was very low, around 1.3%, and there was zero more than moderate paravalvular leak. And in the TVT registry, mortality was lower with TAVR in patients with bicuspid aortic valve than in patients with tricuspid TAVR. And again, paravalvular leak was almost equivalent. It was 2.1 to 2.7. Another issue is to consider is the morphology of the valve and the classification, whether it's unicuspid, bicuspid, and the Rafi numbers, and so on. This was studied in the bicuspid TAVR registry in about 1,000 patients, and they found that it's not the morphology, it's the amount of leaflet calcification and Rafi calcification that's related to mortality. And the mortality double if there is one criteria, either leaflet or Rafi calcification, and it's quadruple, which goes up to 25% if both features are there. And it's better to avoid TAVI in these patients and prefer to send them to surgery. So it's not the morphology, it's the amount of leaflet calcification and Rafi calcification that matters. So again, in young, if we move to young with the bicuspid aortic valve, the outcome is better than in tricuspid. Paravalvular leak is rare. We have excellent hemodynamic with TAVR by echo, and patient is suitable if he has no coronary artery disease, no aortopathy or valvular heart disease, and if there is mild leaflet and Rafi calcification. Another issue is the durability, and many trials looked at durability in these patients. 8 studies were published with an average follow-up of 8 years. In these studies, durability was better than what was reported in surgery, with severe degeneration less than 2.5% and failure less than 7.5% at 8 years, while the reported incidence in surgical patients is around 15% at 10 years. Again, the result from the Notion 8 years trials showed that the TAVI is associated with almost 58 relative risk reduction in the risk of valve degeneration compared to surgery. So durability of TAVR valves is better than surgery according to the current evidence. What about the issue of valve and valve? If we consider TAVI in young, they may need another intervention. The recent studies showed that it is feasible, it's safe, it's associated with low mortality, low risk of coronary obstruction, and excellent hemodynamics, and it may be superior to surgical explantation. In the REDO TAVR registry, TAVR and TAVR was safe with low risk of complication and low risk of paravalvular leak. The hemodynamics at 30 days was excellent. It was the maximum gradient was around 13. Coronary flow obstruction was very low, less than 1%, and mortality at 30 days was around 1.4% for patients with failed TAVI procedure. Again, in a recent publication from the Medicaid services showed that REDO TAVR is superior to explantation and surgery in terms of mortality at 30 days with 50% reduction in mortality compared to surgery, and lower MACE, and in patients who were done after 2014's 1-year mortality was also lower with surgery compared to TAVI. So in surgical explantation is still an issue. We need more experience in that because around 1/4 of patients will need either ascending aorta or root replacement. So what do we need? We need imaging to guide our future TAVI lifelong management in young patients. From CT, we can predict which patient will develop paravalvular leak, especially if calcium score is more than 4, or there is calcification at the device landing zone. These patients should go to surgery. Again, we can predict the risk of pacemaker implantation by knowing the depth of the membranous septum. If it's less than 3, they have almost 30% risk of pacemaker implantation and should go to surgery. Again, we can predict the risk of coronary obstruction and risk and feasibility of coronary access, and we can predict the possibility of TAVR and TAVR from the first TAVI. So probably in young patient, the best option with the lowest risk will be TAVR first, SAVR, and then probably TAVR again. Thank you.